Infective endocarditis is infection of the endocardium, the inner lining of heart chambers and the covering of heart valves. Infection is caused by microorganisms, mainly bacteria, that have managed to enter the bloodstream. Except for rare cases caused by massive blood infections or highly virulent organisms, a healthy heart is usually resistant to infection. This is because bacteria do not easily adhere to the surface of an intact endocardium. Constant flow of blood also helps prevent bacterial attachment, and the bacteria are usually destroyed by the immune system before they can cause infection. An abnormality of the endocardium is typically required for endocarditis to occur. Major risk factors include having prosthetic valves or other intracardiac devices, congenital heart defects, heart valve disorders, hypertrophic cardiomyopathy, and previous endocarditis. Endothelial injury allows for either direct colonization by virulent organisms or the formation of blood clots, which then become the attachment site for bacteria. Infection of the endocardium occurs most often on the left side of the heart. Organisms that cause endocarditis may come from distant infected sites, such as skin abscesses or urinary tract infections, or they may enter the body through a contaminated central line or injection. Bacteria of the normal flora of the mouth can also infect the endocardium if they get into the bloodstream, such as during invasive dental procedures. Causative organisms may vary depending on the source of infection, but streptococci and staphylococci are responsible for the majority of cases. Vegetations formed by bacterial growth may cause heart valve dysfunction, which can be heard as murmurs and may lead to congestive heart failure. Myocardial abscesses and tissue destruction may lead to cardiac conduction problems. Pieces of bacterial vegetation may break free, forming so-called emboli. Emboli travel in the bloodstream and may block arteries. Right-sided infections produce emboli that travel to the lungs, causing pulmonary infarction and respiratory symptoms. Left-sided infections can send emboli to any other organs, including the brain, kidney, spleen, and the heart itself. Tiny emboli may also travel to the skin and eyes, producing small red streaks under fingernails, on fingers, toes, and the whites of eyes. Other symptoms include fever, chills, fatigue, and fast heart rates. Symptoms can develop abruptly or gradually, depending on the type of endocarditis. Endocarditis must be suspected when fever is combined with a heart valve disorder, especially when characteristic symptoms such as reddish spots on fingers or the whites of the eyes are present. But diagnosis usually requires evidence of blood infection and imaging studies such as echocardiography to show vegetations on heart valves or damage to the heart tissues. Treatment consists of several weeks of intravenous antimicrobial therapy. Identification of the causative organism by blood culture is vital to determine appropriate antibiotic regimens. Empiric antibiotic therapy before organism identification may be necessary in seriously ill patients. Some cases may require surgeries to repair or replace heart valves. Potential source of infection must be removed.
Peripheral artery disease, PAD, is a common circulatory.
Okay, so infective endocarditis. Now we'll go for little details. We have seen one nice video demonstration on infective endocarditis. So definition: inflammation of the endocardial surface of the heart, including heart valves, which is caused by certain microorganisms. And types: infective endocarditis, non-bacterial thrombotic endocarditis, and Liebman's-Sachs endocarditis. So infective endocarditis, here microbes colonize in the heart valves from viable vegetations. Two types, one is acute, another one subacute, diagnosed via Duke's criteria. Non-bacterial thrombotic endocarditis, This variant characteristically, this virus characteristically occur in the setting of cancer like adenocarcinoma, and Limb-Mann-Sachs endocarditis occur in the setting of cancer like adenocarcinoma. So here is the diagram. Major forms of vegetative endocarditis: acute rheumatic fever phase rheumatic heart disease, then infective endocarditis, non-bacterial thrombotic endocarditis, and Limb-Mann-Sachs endocarditis. Why rheumatic heart and valve replacement patients are more susceptible to infective endocarditis? Blood usually flows smoothly on valves. When these valves are damaged, as in rheumatic heart or in valve replacement, there will be an increased chance of bacterial colonization on damaged tissue. Also, if there is any clot or emboli adjacent to the valve, then they can also enhance colonization of the bacteria. Pathophysiology of rheumatic heart disease: acute rheumatic fever result from host immune response to group A streptococcal antigen that cross-react with host proteins, in particular antibodies and CD4 with T cell directed against streptococcal M protein. Can also in some cases recognize cardiac self-antigen. That is the fact. Again, acute rheumatic fever result from host immune response to group A streptococcal antigens that cross-react with host protein, in particular antibodies and CD4 T cell directed against streptococcal M protein can also in some cases are recognized as self-antigen. So antibody binding can activate complements. Antibody binding can activate complements as well as recruit FC macrophages activation within Eschop's bodies. And damage to heart tissue may thus be caused by a combination of antibody and T cell mediated reaction. Both antibody and T cell mediated reaction may cause damage to the heart tissue. So this thing will happen repeatedly. So recurrent inflammation, progressive fibrosis, narrowing and stiffening of the valve leaflets with commissural fusion, reaction of the leaflet edges, valve thickening, calcification leading to stenosis. We can make it simple. Recurrent inflammation, progressive fibrosis, because after inflammation there is one stage of fibrosis, resolution by fibrosis. So recurrent inflammation and resolution by fibrosis, narrowing and stiffening of the heart valves with valve thickening, calcification leading to stenosis. Okay. So gross finding. What can you see microscopically in infective endocarditis? Eschop's body, a form of granulomatous inflammation which consists of a central zone of degenerating extracellular matrix infiltrated by lymphocytes, plasma cell, and anti-shock cell, anti-shock cells, activated macrophage, also termed as caterpillar cell due to wavy nuclear outlines found in all layers of heart, pericardium, myocardium, and endocardium. Okay, gross finding, I think we can answer in this way. Also, we will see in our pop-up notes. Gross finding in acute phase, valvular vegetation along the line of closure of the heart valve. So this is the acute phase finding, gross finding, valvular vegetation along the line of closure. And it will affect very less on the cardiac function. So valvular vegetation in acute phase, valvular vegetation along with the line of closure, and in chronic phase, commissural fibrosis, because in pathogenesis we have seen inflammation, recurrent inflammation, progressive fibrosis. So this is recurrent, means it is chronic. So in chronic phase, commissural fibrosis, valve thickening, and calcification. Again, commissural fibrosis, valve thickening, commissural fibrosis, valve thickening, and calcification. In chronic phase, we will get commissural fibrosis, valve thickening, calcification, and shortened and fused chorda tendon. This is fish mouth shape. Okay, this is gross finding or macroscopic finding or naked eye finding. Now, microscopically, what we'll see Eschop's body. Only that much is sufficient. Eschop's body. This is a form of granulomatous inflammation which consists of a central zone of degenerating extracellular matrix infiltrated by lymphocyte, plasma cell, activated macrophage, and caterpillar cell. Okay, found in all three layers of the heart, pericardium, myocardium, and endocardium. In short, we can say Eschop's body in all three layers of the heart, pericardium, myocardium, and endocardium. What to see macroscopically? What to see macroscopically? Eschop's, okay, macroscopically, Eschop's nodule and fibrinoid necrosis. Here we'll go get Eschop's nodule and fibrinoid necrosis. Eschop's nodule and fibrinoid necrosis. Okay. Now, investigation to identify vegetations, 2D echo. 2D echo we can do either by transthoracic or transesophageal, but transthoracic is most commonly used, but most specific for infective endocarditis is transesophageal. Means we will insert the probe through the mouth in the esophagus, and at the mediastinum in mid-esophagus level we will do the scan. It is more specific for infective endocarditis. Okay, now what to look for in echo? First, we will look for valvular regurgitation. Valvular regurgitation. A regurgitation jet more than 1 centimeter in length and peak velocity more than 2.5 per second. Okay, so valvular regurgitation. First we will look for in echo. First we will look for valvular regurgitation. Then leaflet valves will be prolapsed. Coaptation failure and thickening, reduced mobility and nodules. So in simple, we can remember like first we will look for valvular regurgitation, then the valves themselves will be prolapsed, thickened, thickness we can remember it is more than 4 mm, and due to this thickness, mobility will be less than the normal, and there could be some nodule like Eschof's nodule again. So valvular regurgitation, first we'll say if we do transesophageal echo, we'll see for valvular regurgitation, then valves will be prolapsed, valves will be thickening more than 4 mm, reduced mobility, and there will be nodules. Then annular dilatation. Annular dilatation. Number 4, chordal elongation or rupture. Chorda tendini, which is attached with valves, they will be elongated or rupture. So chordal elongation or rupture, and increased echogenicity of subvalvular apparatus. Increased echogenicity of subvalvular apparatus. Pericardial effusion. Yes, this is important. Pericardial effusion. We will get pericardial effusion. Chorda tendini elongation or rupture. At least 3 to 4 points we have to remember. And ventricular dilatation and dysfunction. Ventricular dilatation and dysfunction. Almost always with significant regurgitation again. So in 2D echo, what we will look for? First, we will look for valvular regurgitation, then valvular leaflet will be prolapsed, thickening, reduced mobility, and nodule. Chorda tendini elongation or rupture, annular dilatation, pericardial effusion, ventricular dilatation or dysfunction. Now, common organism, viridans, Streptococcus viridans, Streptococcus bovis, Streptococcus viridans or Streptococcus bovis, coagulase negative, again Staphylococcus epidermidis. So Streptococcus viridans, one is Streptococcus viridans, and other is Staphylococcus viridans, Streptococcus bovis. Okay, we got two Streptococcus viridans, Streptococcus bovis, and Staphylococcus epidermidis. This is coagulase negative. So we can say Streptococcus viridans, Streptococcus bovis, Staphylococcus epidermidis, Enterococci, Heck group of microorganisms, oropharyngeal commensals. Okay, like Heck groups of microorganism, we can remember one or two at least. Haemophilus species, Cardiobacterium hominis, Haemophilus species, Cardiobacterium hominis, Echinella cordens, and Klingela species. Echinella cordens, Klingela species. Again, Homophilus species, Cardiobacterium hominis, Echinella cordens, and Klingela species. Now, diagnosis depends on Duke's criteria. Duke's criteria describing to diagnose infective endocarditis, there must be two major criteria. This is the single diagnostic criteria. If there is two major criteria, no need of any other minor criteria. But if only one major criteria, we need additional three minor criteria to diagnose. And last one, there is no major criteria, but five minor criteria. So that is another criteria for diagnosing infective endocarditis. Again, in short, Diggs criteria, selection criteria of infective endocarditis, two major criteria without any minor criteria, one major criteria with three minor criteria, and number three, no major criteria but five minor criteria. So what are the major criteria? First, typical microorganism consistent with infective endocarditis from two separate blood culture. Two separate blood culture showing typical organism like Staphylococcus bovis, or Streptococcus viridans, or Staphylococcus what was the epidermidis, or Enterococci in consecutive two sample in blood culture, it is showing positive. So first criteria, typical microorganism consistent with infective endocarditis from two separate blood culture. Number two, persistent positive blood culture. Persistent positive blood culture. So first one, typical microorganism from two separate blood culture. Number two, persistent positive blood culture. And if a single positive blood culture for Coxicella burnetii or phase 1 immunoglobulin G antibody titer is more than 1:800, this is diagnostic for infective endocarditis. So three criteria. One is typical microorganism consistent with two separate blood culture. Number two, persistently positive blood culture. And number three, single positive blood culture for Coxicella burnetii or phase 1 immunoglobulin G titer, antibody titer more than 1:800. Then if any two of these criteria present, then it is diagnosed as infective endocarditis. Now, evidence of endocardial involvement, how? By echocardiogram positive for infective endocarditis. We have seen what we look for, 2D echo. If there is abscess, new partial dehiscence of prosthetic valve, new valvular regurgitation, note, worsening or changing of pre-existing murmur not sufficient. Okay, so these are the major criteria, 1, 2, 3. Now minor criteria. Minor criteria, we said for the diagnosis, if 5 minor criteria is there, then it is diagnostic for infective endocarditis. Or if there is 3 with 1 major, there is also diagnostic criteria. So minor criteria, predisposing factor, like if patient is IV drug user or any previous heart condition, any valvular surgery, or any congenital valvular disease, there is one. So predisposing factor is one criteria. Then vascular phenomenon like major arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, and Genius lesion. Genius lesion we see in the hand. We'll see. And microbiological evidence, positive blood culture, but does not meet a major criteria as noted above, or serological evidence of active infection with organism consistent with infective endocarditis. Hello. Hello. Yes. Okay. Okay. Uh-huh. As actually directly, I have not seen the patient. Lindsay's sister sent those two approval, right? And she told it is not emergency. I think patient also not here. I think not here because they are not in the ER, not in the ward. They didn't say anything. There is any other patient. I think so. Yeah. Oh, what about that update? Any update about this? Okay. Okay. Mm-hmm. Mm-hmm. Because patient also not willing to stay and they are planning to go home. That's why, but it is necessary to get the approval. Okay, thank you. Sorry for the interruption. So, yes. So microbiological evidence, because in the major criteria we have said at least 2 positive uh, blood culture for the organism which causes infective endocarditis, or persistent positive blood culture, and if any single, even if a single positive culture with the organism of Coxsacilla burnetii. So now if any blood culture comes positive but not with this organism, it is not Coxsacilla burnetii, or it is not with Staphylococcus bovis or Staphylococcus viridans. I mean, those organisms which causes infective endocarditis, but it is culture positive, maybe with some other organism. If anything like this happens, so it will be also a minor criteria. Now, fever, if patient have fever more than 38 degree with chills, fever with chills, and immunologic phenomenon, because our body, when get any infectious pathogen, our body immune response will try to fight against them, and there will be some presentation like glomerulonephritis, Osler's node we say in the hand, then Roth spot will get in the eye, in the retina, Roth spot, and rheumatoid factor in the limbs or in the so any of these will be also a minor criteria, and echocardiographic finding like consistent with endocarditis but do not meet a major criteria, as we said before, that what we look for in 2D echo. First, valvular regurgitation, then valvular prolapse or thickening more than 4 millimeters. Suppose we got thickening, but it is not more than 4 millimeters, so it will not be a diagnostic criteria for infective endocarditis, but he has. So this type of echo finding will be regarded as minor criteria. Okay. Now in ECG also, in ECG there will be feature of heart block and arrhythmia. Causes and risk factor of infective endocarditis already we have seen, and here you can see acquired valvular heart disease. Acquired valvular heart disease may be congenital with stenosis or regurgitation. Acquired valvular heart disease with stenosis or regurgitation, anything, because heart valve is diseased, so organism gets a easy access to those valves to infect. Any valve replacement, surgically replacement of the valve, structural congenital heart disease, structural congenital heart disease, including surgically corrected, but not the major like atrial septal defect, fully repaired ventricular septal defect, or patent ductus arteriosus. Not those, but minor other small valvular heart defect, which is corrected surgically. Also, if there is any valve replacement, though they are susceptible for this infective endocarditis. And previous infective endocarditis, also hypertrophic obstructive cardiomyopathy, and any implantable cardioverter defibrillator. Okay. Others like cyanotic congenital heart defect, it will come in the same in this structural congenital heart disease. And colorectal cancer like Streptococcus bovis, colorectal cancer, Streptococcus bovis. And we said that Streptococcus bovis is a organism for infective endocarditis. Now, from the ascending route, like urinary tract infection, intravenous drug user, rheumatic heart disease, HIV patient, immunosuppression, malignancy also immunosuppression, diabetes immunosuppression, alcoholic, and tooth extraction directly, oral microorganism, I mean from the oral route, when any dental procedure going on and blood vessel is exposed, so easy access to systemic circulation from the oral cavity organism. If any of these like Streptococcus viridans or Streptococcus bovis, it is from oral cancer like Streptococcus viridans, Streptococcus bovis, or Staphylococcus epidermidis, or any of these can directly invade. So complication of infective endocarditis, directly it will affect on the heart, also it will affect systemic. So in the heart, we have seen in the video very nicely, in very simple, because this is our heart. This is our heart. So tricuspid valve, bicuspid valve, and from here pulmonary, both side, from here arch of aorta. So we have seen that infective endocarditis mostly affect the mitral valve because here pressure is less. Okay, so complication, how it can happen if this vegetation or this thromboemboli or thrombus dislodge from the left side of the heart. This is left side, right side. So it will come into left ventricle. From left ventricle, it will get the arch of the aorta. So it will ascend, and from here we know brachiocephalic trunk, common carotid, and left subclavian. So with this, it will go to the systemic circulation, and we know in the root of the arch of the aorta there is aortic sinus, from where we get coronary arteries, right coronary artery, left coronary artery. If it occlude or block any of the coronary arteries, patient will develop acute myocardial infarction, also pericarditis, there will be arrhythmia, valvular insufficiency, congestive cardiac failure. Okay, now yes, this thing, acute myocardial infarction, pericarditis, arrhythmia, valvular insufficiency, this thing will happen if it comes from the left chamber or from the mitral valve. But if it happens in the tricuspid valve and from here this thrombus will come in the right heart, I mean right ventricle, and from here it will trigger congestive heart failure. So right heart failure will develop from this consequence. And aneurysm, intracardiac abscess, arterial emboli, and non Now, Janus lesion. This is non-pain, non-tender. I mean, not painful. Janus lesion. It is not non-painful nodular or macular red lesion due to septic emboli, which deposit bacterial forming microabscess. This is not painful. Splinter hemorrhage. We will see. This is oslar nodes. Oslar nodes in the index finger. You can see oslar nodes in the index finger. Oslar nodes in the index finger. This is painful because it looks like kind of like abscess, so it will be painful. Oslar node, painful. Raised red lesion due to immunocomplex deposition, and Janus lesion. Janus lesion in the palm of a 36-year-old male with Staphylococcus endocarditis. Nodular or macular red lesion. Nodular or macular red lesion. Multiple red lesions, but it is not painful. Splinter hemorrhage. We don't have any picture, but splinter hemorrhage kind of this. See here, we can see little, but it will be in the nail bit. Splinter hemorrhage. And clubbing, as we know, the curvature of the nail will increase, and there will be diminish this diamond shape. Now, sign and symptoms of infective endocarditis. Already these 4 sign: oslar nodes, Janus lesion, splinter hemorrhage, and clubbing, along with this fever, Roth spot, murmur, anemia, and emboli. So now come to treatment. Treatment depends on the local hospital policy and local. So it depends on the hospital antibiotic policy. Also, we need to involve the microbiologist. Okay, sister, I will come. It will take little time, maybe 15 minutes. I will come. Okay, yeah. Valve vegetation, inside the valve vegetation, where there is no blood supply at all. Also, bacteria form a biofilm. They themselves cover with a biofilm. They protect themselves by making a, suppose this is a prolapsed valve of mitral valve, and this is inside. Okay, it is thickened. Inside there is microorganism, Staphylococcus viridans, and they have made a shield against their surface. So it is a biofilm. First of all, there is no blood supply to come here, and independently they are infecting. I mean, and second, they are remaining inside the valve in the vegetation, and organism, they form a biofilm, glycocalyx covering that shield from the antibiotics. This is why we need to give antibiotics for 6 weeks. If infective endocarditis occurs in tricuspid valve in young person, tricuspid valve here in the young person, and this is mitral bicuspid. Tricuspid valve, it will come from the venous return, like superior vena cava or inferior vena cava. Usually, the intravenous drug user in the vein, they use the drug in the vein. So vein will carry the blood through the venous system, and venous system carrying the blood into the right atrium, and from right atrium they are going to right ventricle through the tricuspid valve. That's why right-sided heart failure or right-sided valvular failure, right-sided heart failure is more susceptible. This is one simple explanation. Another, there will be consequence due to the consequence of pulmonary embolism. Pulmonary hypertension will develop, and right valve, right heart has to pump more forcefully, I mean with the more pressure. So ultimately right heart failure will develop. If infective endocarditis in tricuspid valve in young person, right-sided heart failure will happen. If no response to medical treatment, then we have the option, particular if any valve is involved, we have to replace the valve, or we have to replace the heart transplantation. matching before heart transplantation HLA antigen or HLA DR, which HLA, HLA DR and ABO. If not matched, what will happen? There will be graft rejection. Which type? Type 1. Type 1 is like immediate or acute, hyperacute. This is actually hyperacute graft rejection. During surgery, there will be graft rejection. How to prevent graft rejection? We have done, HLA, DR and ABO compatibility checked, but we have to take precaution by starting immunosuppressant therapy, TMS, okay, tacrolimus, mycophenolate and steroid. Tacrolimus, mycophenolate, steroids. We know not only here, for other organ transplant also, we keep the patient in this immunosuppressant therapy. Now, there is some side effect if we use steroid for long term, because it will suppress the immunity. So opportunistic organism like bacteria and viral infection will occur, especially cytomegalovirus. If rejection happens before 6 months, early rejection, it is due to cytomegalovirus. And if it is after 6 months, this is by Epstein-Barr virus. They will present as like leukemia or lymphoma. So cushingoid features like obesity, muscle weakness, hirsutism, and stria on the abdomen or thigh or in the arm. Again, opportunistic bacterial infection and viral infections such as Epstein-Barr virus, cytomegalovirus. Cushingoid features like obesity, muscle weakness, hirsutism, and stria, and cardiovascular complication like fluid retention and hypertension in endocrine, diabetes mellitus, and musculoskeletal osteoporosis, avascular necrosis, proximal myopathy. This patient came after 6 years with high blast cells and lymphocytes. What do you suspect? This is, in fact, this patient may have lymphoproliferative disorder, which may cause leukemia or lymphoma. Okay, mechanism of action of immunosuppressant. How do immunosuppressant work? They work by 4 mechanisms. One is the 4 class of immunosuppressive drugs: corticosteroid, for example, prednisolone, methylprednisolone. They act by killing T cell. They act by anti-inflammatory, killing T cell. Okay, corticosteroids, they act by killing T cell, anti-inflammatory effect. Cytotoxic drugs like cyclophosphamide, azathioprine, methotrexate. This is cytotoxic drug. CAME. Cytotoxic drug is CME, like clinical medical presentation. Cyclophosphamide, azathioprine, methotrexate, mycophenolate. Okay, no need. They block the division non-specifically. They block cell division non-specifically, because we know cancer cell divide in a disorganized method. We know regular or regulated cell division is mitosis and meiosis, but in cancer cell it is not organized. So in generally, cytotoxic drug inhibit or block the cell division. cytotoxic drug. So it affects both normal and abnormal cell. I mean cancer cell and normal cell also. That's why. Okay. And immunophilins like cyclosporin, it blocks T cell response. Corticosteroid kill the T cells, and immunophilin blocks T cell response. And lymphocyte depleting therapies like monoclonal antibodies, it also kill T cell, non-specifically kills activated T cell. Okay. After valve replacement, why on warfarin? To prevent thromboembolism. To prevent thromboembolism, mechanism of action of warfarin, they block vitamin K antagonists, thus inhibit the clotting factor. Mechanism of action of warfarin, they inhibit the clotting factor 27910, that is 1971, and protein C. How to monitor? By checking INR. Normal will be 1.5 to 2. Reversal, how we do? If we want any emergency or elective surgery, we do the reversal with vitamin K. And if elective surgery, if elective surgery, then we do it with vitamin K, because it is slow process, it takes some time. But if urgent surgery like emergency, then we will correct it by fresh frozen plasma and prothrombin complex concentrate, PCC, prothrombin complex concentrate, PCC, prothrombin complex concentrate. Now right-sided vegetation, tricuspid valve mainly in IV drug users. Prophylaxis against infective endocarditis. Antibiotics prophylaxis against infective endocarditis is not recommended routinely. Antibiotic prophylaxis against infective endocarditis is not recommended routinely. Okay. For people undergoing dental procedures, for people undergoing non-dental procedure at the following sites: upper and lower gastrointestinal tract, genitourinary tract, antibiotic prophylaxis against infective endocarditis is not recommended routinely. Okay. For the people undergoing dental procedure, for people undergoing non-dental procedure at the following sites: upper and lower GIT tract, genitourinary tract. This includes urological, gynecological, and obstetric procedure and childbirth. Upper and lower respiratory tract, this include ER, nose, and throat procedure and bronchoscopy. Chlorhexidine mouthwash should not be offered as prophylaxis against infective endocarditis to people at risk of infective endocarditis under dental procedure. Okay. We have finished infective endocarditis. Now aortic stenosis, and then the station. Aortic stenosis, little rapidly we'll try to finish because I have to go to ward. Okay, aortic stenosis. Also see questions from the previous. Okay, clinical picture. See preoperative aortic stenosis as okay. Causes: aortic stenosis. Aorta is stenosed. Aorta is stenosed. Means in the previous, here we have seen in the right heart there will be pulmonary trunk, and in the left there will be aorta, arch of the aorta. So in both valve, aortic stenosis, pulmonary stenosis can happen, but specifically now we are going aortic stenosis in the left heart. So post-inflammatory scarring, rheumatic heart disease, senile calcific aortic stenosis, calcification of congenitally deformed valve. Okay, this is a tricuspid valve. So congenitally, if there is any defect, later on there could be calcification on the valve. So calcification of congenitally deformed valve, senile calcific aortic valve. Due to senility, there will be calcification on the aortic valve. Also, if any patient has already congenital some aortic valve disease, they are more prone to have calcification on their defected valve. Also, post-inflammatory scarring in rheumatic heart disease. Causes of sudden death in aortic stenosis, because we know when aorta through the aorta, blood will go, and from here right and left pulmonary coronary arteries also coming, and that is giving the supply to the heart. So if there is any stenosis, then MI is very susceptible to develop. So cause of sudden death in aortic stenosis. Sudden death in aortic stenosis is myocardial infarction and aortic distension, rupture, aortic dissection. Sorry, aortic dissection. Yes, aortic dissection. How stenosis occur? Lipid accumulation, inflammation, calcification, valve thickening, and stenosis. Very simple. Lipid accumulation, inflammation, calcification, so valve thickening and stenosis. So this is kind of dystrophic calcification of the aortic valve. We know calcification are of two types. One is dystrophic calcification, another one is metastatic calcification. In metastatic calcification, okay, in dystrophic calcification of the aortic valve, view looking down onto the unopened aortic valve in a heart with calcific aortic stenosis. It is markedly narrowed or stenosed. The semilunar cusps are thickened and fibrotic, and behind each cusp are irregular masses of peeled up dystrophic calcification. So what is aortic sclerosis? AV valve disease with significant gradient across the valve can progress to stenosis. Why bicuspid valve has high risk of stenosis in a long term? Bicuspid valve, not tricuspid. Bicuspid means left. Because the mechanical force that normally distributed to three valves, that is in tricuspid, is now distributed to two valves only. So they are more prone to develop. Also pressure is okay, because the mechanical force that normally distributed to three valves is now distributed to two valves. And in our heart, we know there is total four valves: aortic valve, pulmonary valve, those are in the two vessel, and in two interventricular septum. In right side, there is tricuspid, and left side bicuspid. So bicuspid is the only two cuspid valve. All other valves are three cuspid, means they have three cusps. That is why it is more prone. Why is bicuspid valve susceptible to? Because in bicuspid valve, there increases risk of stenosis and stasis of blood. Pathophysiology, how does it lead to death? Okay, last page, I believe. I'm in a little hurry actually. As the aortic valve progresses from sclerosis to stenosis, the left ventricle encounters chronic resistance to systolic ejection. The left ventricle encounters the chronic resistance to the left ventricle encounters chronic resistance to systolic ejection. So thickening of the left ventricular wall, there will be hypertrophy of the left ventricular wall, which will effects of left ventricular afterload include decrease left ventricular myocardial elasticity. This is very dangerous. So it will be ultimately decrease left ventricular myocardial elasticity and coronary blood flow. As left ventricular myocardial elasticity is reducing, so coronary blood flow also will reduce and increase myocardial workload oxygen consumption and mortality, and increased myocardial workload, oxygen consumption and mortality. Okay, this is the mechanism of MI. Through MI, how there is death. Late manifestation of left ventricular hypertrophy. So first we are getting left ventricular hypertrophy, which is causing thickening of the left ventricular wall, that is hypertrophy, and it is decreasing the left ventricular myocardial elasticity and also decreasing coronary blood flow, which is increasing myocardial workload, oxygen consumption, and ultimately mortality. Late manifestation of left ventricular hypertrophy include a smaller left ventricular chamber. This is very obvious. Left ventricular hypertrophy includes a small left ventricular chamber size, which decreases the preload and worsens systolic dysfunction. This results in insufficient stroke volume, cardiac output, and ejection function. Insufficient stroke volume, cardiac output, and ejection finally. So finally, backward transmission. Okay. Finally, backward transmission or increased left ventricular pressure to the or increases left ventricular pressure to the lungs may cause pulmonary venous hypertension. Increased left ventricular pressure to the lungs may cause pulmonary venous hypertension and reactive vasoconstriction of the pulmonary vasculature. Aortic valve endocarditis after a while, weakness in arm. Why? Because of stroke, thromboembolism, which leads to cerebrovascular stroke. Anterior cerebral artery, middle cerebral artery, mainly the middle cerebral artery. Yes, the upper limb. Which coagulation system will not be affected by porphyrin initially? Intrinsic pathway. Define thrombus. Thrombus is defined as solid material formed from the constituents of blood. It is a solid material formed by the constituents of blood and it is mobile. What complications of non-displaced thrombus? It may cause infection and inflammation. Surgical options of valve replacement. One is mechanical valve, tissue valve, Rose procedure, and non-surgical transcatheter aortic valve replacement. What test do you do in thrombus is infected CBC, CRP, ESR, and blood culture. What is CRP? Acute phase protein produced by the liver in response to inflammation. If metallic valve replacement was done and the patient developed infective endocarditis, why the valve should be removed? Because if metallic valve replacement was done and the patient developed endocarditis, why the valve should be removed? Because the valve will not, the valve will be a septic focus. Yes, it has no blood supply and it will form a biofilm and will be default in treat with antibiotic. The valve will be dehiscent. Valve vegetation can lead to thromboembolism. That's why that valve should be removed. The valve will be a septic focus and this valve will be dehiscent. Okay, if we found microscopic branching hyphae on a removed metallic valve, what's the cause? It is candida. This is a fungal infection. This is a fungal because fungi only produce this branching hyphae. This is candida aspergillus. Examiner waiting. Okay, aspergillus, microsporium, trichophyton, and epidermophyton. Postoperative metallic valve replacement instruction will give start warfarin drugs in use, prophylactic antibiotic, and caution with MRI. Caution with MRI. Okay, mechanical valve versus tissue valve. Mechanical valve, excellent durability, 95% at 10 years, and low rate of reoperation. Need warfarin, easy to insert, thromboembolism 1 to 2% a patient yearly, and bleeding we will discuss in Word file. Very rapidly we'll try to discuss. Station 1. These are the question. 56-year-old lady with bicuspid aortic valve is admitted for laparotomy. Patient has a bicuspid aortic valve, but now admitted for laparotomy, maybe for some other reason. But now, why is bicuspid aortic valve susceptible to infective endocarditis? Because bicuspid valve has only two valves, which increases risk of stenosis and stasis of blood. Pathogenesis of infective endocarditis in bicuspid valve. In bicuspid valve, there is narrowing, which cause stasis, which increase the chance of bacterial colonization and damaged tissue, with recurrent attack of inflammation when it will be progressive fibrosis, narrowing and stiffening of the valve, which can lead later on to stenosis. Investigation of choice to identify vegetation of in infective endocarditis, we do 2D echo, either transesophageal or transthoracic, but transesophageal is more specific. What are you looking for in 2D echo? We discussed it in details. What is the cause of sudden death in aortic stenosis? MI and ruptured aortic dissection. Clinical picture of aortic stenosis. In mild aortic stenosis, patient will be asymptomatic. In moderate cases, patient might have angina, syncopal attack, and dyspnea. And in severe causes, patient will have MI and sudden death. Now, pathophysiology of aortic stenosis. How does aortic stenosis lead to death? We have seen this on in details. What are the surgical options to treat aortic stenosis: mechanical valve replacement, tissue valve replacement, and Rose procedure. Okay. What is the difference between mechanical and tissue valve? We have seen this one. What is the non-surgical option for valve replacement? Transcatheter aortic valve replacement, aortic valve balloon, or valvuloplasty. In metallic valve replacement was done and the patient developed infective endocarditis, will be what will be your next step and why? I will remove the valve because the valve will be a septic focus and valve will be dehiscent and it has no blood supply and it will activation activated with the প্রথম beam to throw. Then fibrin will form fibrin clot. How? Also suspect that thrombus is infected. We'll do CBC, inflammatory markers like CRP and ESR, and blood culture. What is CRP? It is a acute phase protein produced by the liver in response to inflammation. And what you look for blood culture? The common organism like Staphylococcus aureus and and